So the long case is a 90-minute station. You'll hear a bell after 8 minutes, which is useful, and then again after 11 minutes. Ignore both of them. This station may be conducted as if it were on more than one session. Read the following scenario, take an appropriate history, and then when you're ready, request the details of a physical exam from the observing examiner. Then you need to outline your diagnostic impressions to the patient, advise on the need for further investigations, if any, outline your conclusions in your proposed management plan, and manage any significant elements of the case. Okay, so again, this is another mock case that I'll walk through. So Mark is a 35-year-old. He's got no allergies. He's been married for 5 years. He works in IT as a game developer. He's adopted, so he doesn't know his family history. He's not on any current medications. He's had all his childhood immunisations. He doesn't usually go to the doctor. He drinks 5 days a week, 2 drinks a night, and then drinks 6 to 8 drinks in one sitting once a month. He tries to be healthy. So again, we're not getting much out of this then. We know that he has a sedentary lifestyle just because he is a games developer. We know that he doesn't like doctors. He probably drinks a bit too much. Okay. So once again, we go and introduce ourselves to Mark and just ask, what can we do for him today? Again, the patient and the examiner have a lot more information than we do, and it's our job to get that information off them. So Mark has been asked to see the doctor by his wife. He and his wife have been married for 5 years. His wife, Danielle, who is also 35, has been found pregnant for 3 years. His wife has been investigated by her GP for subfertility, and the GP couldn't find anything. The doctor then suggested that Mark might need to be investigated for subfertility prior to referral to a specialist. Mark is heavily obese, and he knows that he doesn't like doctors. They always talk about his weight. He's tried everything and nothing has seemed to work. He doesn't know how he ended up this heavy. He is shy and doesn't like taking up much space in the room. Danielle is also morbidly obese, and they are comfortable with each other. They are good friends and enjoy each other's company. The only issue between them, besides Danielle's obsession with falling pregnant, is that they sleep in different beds. This is for a couple of reasons. They are both too big to sleep in one bed, and he snores, which keeps Danielle awake. Mark has no children that he is aware of. He doesn't know his family history, and he is uncomfortable talking about himself, let alone sex. Again, this is more of the information that the patient and the examiner has. He's tired all the time. It takes an effort to do anything. He has assumed that that was because of his weight. He doesn't like going out, and he and Danielle don't have many friends. He normally doesn't have any problems getting an erection or having a morning erection, but recently he has noticed that it's a bit difficult maintaining an erection. Danielle is using Maybe Baby, and during the time she is ovulating, they're having sex daily. Mark has no previous medical history of note, including no undecented testes, no testicular trauma or arthritis. Mark does want kids, but isn't as obsessed as Danielle is. He knows that this is all she has ever wanted and thinks she'd be a great mum, but he is more pragmatic. He feels a bit trapped because he loves Danielle and would do anything for her, but when he tells her that he would be happy even if they didn't have kids, she thinks it's some sort of betrayal. He doesn't quite understand that. And he's scared that if he tells her that he doesn't want any investigations or expensive treatment, then she'll leave. Mark went through puberty quite late, around 16 or 17. So that's the information that they've got, and you've got to get that off them. Oh, sorry, just more information that they had. He was the shortest in high school until his senior year, and then he grew so much that he got stretch marks on his belly and his legs. Never been able to grow a decent beard. He didn't enjoy school much because he got called Four Eyes and tended to be bullied. He also found English quite difficult, and he was never very sporty. So this is the information that's freely given. But he will freely tell you that he's been asked by his wife to come see you, that they've been trying to fall pregnant for 3 years. His wife, he loves his wife, but he's not sure about going down the fertility route. That he and his wife assume that there must be something wrong with him because the GP examinations are normal. He loves his wife, they're good friends. He does snore, doesn't know how he ended up quite happy, so heavy. He's not really obsessed about kids. He's a bit more pragmatic about the kid option than she is. Now, there's some information that will only be given if it's specifically asked. Does he have any kids? So you'd have to ask, do you have any kids? Is there any family history of people not being able to have kids? Besides, you know, the child issue, how else is life going? You know, is there any other problems, anything else that you're concerned about? So then he would tell you about being tired all the time and the effort that it takes to do anything. You'd have to ask him about, you know, does he enjoy going out with his friends? Does he enjoy doing things like he used to enjoy doing them? And that would give him the chance to say, well, no, we don't really do anything. You'd have to specifically ask him about erections. You'd have to specifically ask him about, well, you know, are you doing anything to try and help you fall pregnant? And at that, he would tell you that they're using Maybe Baby and how often they're having sex. You'd also have to ask a puberty history in order to get the rest of that information about his puberty and his growth. There's also information that can be revealed if adequate empathy is shown. So if you are open, empathetic, he'll let you know that he's feeling a bit trapped, that he doesn't quite understand where Danielle's coming from, that he's a bit scared, you know, that he didn't enjoy school, that he felt teased and bullied and he wasn't very sporty. Okay, so once you've finished your history and you're happy, then you ask the examiner, you say, well, now I would like to do an examination. The examiner will then give you this card. You'd say, well, obviously before I do the examination, I would have washed my hands. So general appearance, he's obviously morbidly obese. He's very quiet and shy. His shoulders are hunched and he seems to be trying to make himself look a bit smaller. Wearing a loose baggy t-shirt that looks a bit old, tracksuit pants. He doesn't make eye contact readily and he has wispy facial hair. He weighs 210 kilos and his height is 190 centimetres, so he's got a BMI of 58. Blood pressure is borderline high, pulse rate is slightly tachycardic. Heart sounds are normal, chest is clear, morbidly obese, difficult to palpate viscera. And he does have quite a abdominal apron. Now, there are, like the history, they will give you stuff freely, but then there's sometimes you have to ask. So you have to ask about, you know, does he have gynecomastia? What are his testes like? What is his penis like? Is there any varicocele? Just that history so far, you'd have to think about depression. So doing a K10, the fact that he's tired all the time and snoring, you'd have to think about doing an Epworth sleepiness score. And the K10 is mildly depressed and the Epworth sleepiness score is positive. Okay. Now, the other thing besides the history and examination that the examiner and the patient have, they've also got what key issues need to be covered in this case. So in this case, you'd want to cover subfertility, the fact that further investigation needs to be done, that he and Danielle may want to consider referral to a specialist and treatment if desired. A specific diagnosis actually can't be made at this consultation. It's nice to be able to list 3 differentials based on the current information and what is most likely, what diagnoses must not be missed. Reassure him that just because Danielle's tests have come up normal so far doesn't mean that it is a problem with him. You need to go through depression. You need to touch on obesity, though handle that sensitively with the patient. You need to touch on sleep apnea and the fact that he needs referral for a sleep study. Also preventative topics such as blood pressure, diabetes, and alcohol. Okay, so when they say, you know, what are your top 3, they will have a list of, you know, the top 10 that they can choose from. So they want to know that you can't make a diagnosis at this time. And again, as I've said, they want to know that you've looked at depression, sleep apnea, obesity, diabetes. You know, think about your subfertility and what that could be secondary to. So at this stage, the most likely and the ones that you don't want to miss are frequent intercourse, having intersex too often. The obesity can cause some subfertility, retrograde ejaculation, you know, if you've got diabetes, low testosterone, low thyroid, other hypothalamic and pituitary diseases, adrenal gland diseases. Klinefelters, this is a dead ringer for Klinefelters, just tall, obese, minimal hair on the face, late puberty, doesn't like never really liked English, communication issues, psychological problems, erectile dysfunction. He sits down for long periods, the testes too overheated, the issue with stress, extended use of computers can also cause some subfertility. The other thing that you can talk directly to the examiner about is, you know, in the back of my head I do have cancers, non-malignant and malignant tumours going on around in my head. I am thinking about chromosome defects such as Klinefelters. Okay, so you'll have to go through your management. So you have to go through talking through that with the patient about the fact that it may not be something wrong with him. Further investigations that you want to do. The examiner might ask you, well, what sort of investigations would you want to do? Discuss timing and frequency of intercourse, so say, or preferably every second day. Look at referral to a fertility specialist. Also have a look at relationship counselling. Just emotionally reflect back to him that couples who, you know, do have subfertility do have a lot of stress on their relationship, and that's really quite normal. And saying, look, we can help you out with that. You know, discuss that he does seem to have a bit of mild depression. And again, it might be good for him to talk through that with someone, but also that organic causes for that need to be ruled out. Obesity, I'll probably touch on that, but I think with this presentation, more of a rapport needs to be established first. Sleep study, send him off. Alcoholic use, again, need to get a bit of rapport happening, and then I'd say, can I see you in a week?